of Medicine and Chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Florida in Gainesville, and a researcher in the VA Medical Center since the late 2011. He actually received his medical degree and completed his internal medicine residency in Buenos Aires, Argentina, before moving to the US for an endocrine fellowship at Baylor College of Medicine. From 1997 to 2011, he was at University of Texas Health Science Center in San Antonio, where he did extensive work on type 2 diabetes, NAFLD, now called MASL, and has published over 250 publications, so very well published. He actually published the first effective pharmacological treatment with pioglitazone for MASL in New England Journal of Medicine in 2006. He has collaborated as a consultant, chair, and co-chair in the development of current MASL guidelines, including the guidelines from the ADA. So it's a great honor to have you here today. We'll learn a lot from your lecture, I'm sure.
Thank you, Leandro. After that kind introduction, I just want to clarify that I stepped down as chief about a year ago to focus on my research, and don't let the word out, but I'm much happier now. So thank you for this, and we're going to just dive into this with a focus for cardiologists. So what you need to know and why. So these are my disclosures, all for the university of all the research supports my research at the university, and a consultant for drugs that will be hopefully in the field of NASH. And many of you only know Miami or Orlando. Gainesville is further north. University of Florida, I think it's ranked 4th among public schools. So I promise if you come to see Mickey Mouse, swing by. I never done a liver biopsy on a first visit to any of our guests, so don't be afraid. And a little bit, this is our campus. I worked for about 25 years at the VA, and we have about 1,200-bed hospital system in North Florida. So we're going to answer 3 questions in the next 45 minutes, trying to leave some 5-10 minutes for questions. Why should a cardiologist learn about MASLD? And the name has changed. Before it was non-alcoholic fatty liver disease, which is still used by many societies. Still, the ADA will shift next year to this term, and I'll tell you why. And so I'm going to do a brief nomenclature update, and then who is at risk of MASLD? And the real issue is that what we were trying to prevent is cirrhosis, not fatty liver itself, but cirrhosis. And if you have fatty liver, you also have a 2- or 3-fold higher risk of hepatocellular carcinoma. So people with diabetes are at a higher risk of liver cancer. We've known that for years, and now the link is steatohepatitis. So after that, we're going to dive in how you diagnose this. And again, a couple of highlights from the ADA and other guidelines. And again, what would be the role of the cardiologist in trying to prevent cirrhosis? And as I'm going to show you, people with steatosis are at increased risk of cardiovascular disease, although the topic is not truly settled completely. So whom to treat? And the good news is what you're doing now with your medications for obesity and diabetes are going to help a lot for fatty liver. Okay, so with that, perhaps if you're going to remember one slide, remember this one. Okay, you are the masters of managing cardiovascular disease. I hope that you're going to also become very good at integrating the liver in your triangle of care. We know nephropathy and SGLT2 inhibitors. Recently, semaglutide showed to reduce the progression of CKD by more than 20%. But now, today, hopefully you'll leave with an idea that the liver is integrated and overlaps with the treatments that you're already doing. So just some basic nomenclature issues. I know many of you are not into this field very much. So fatty liver can be for many reasons. So if you're going for a happy hour every evening after a hard day of work, don't worry, you already have a fatty liver, but that's an alcoholic fatty liver disease. There are some viral infections, medications. So once you rule out all those secondary causes, you may have just steatosis without inflammation, called MAFL or now MASL, and I'll get into that change in a moment. Or you can have inflammation with hepatocyte injury and progressive fibrosis. So really the risk identification is not to identify if you have steatosis, which already 70% of your people with obesity or type 2 diabetes have, but you want to know who are those who have fibrosis because they are on a pathway to cirrhosis. This is like people with diabetes and proteinuria. If you don't do anything, they're going to end up in dialysis, but also, as in chronic kidney disease, most cardiovascular disease, which you can prevent. So our target is fibrosis, not fat in the liver, although steatosis outlines or highlights a group of people who are at higher cardiovascular risk. The second thing is that the name change, creating substantial confusion among non-hepatologists. So fatty liver disease was dropped because fatty was felt to be offensive or stigmatizing for some patients. And so they changed it for the Latin name of steatotic liver disease, which is an umbrella term for any kind of steatosis in the liver, okay? Alcohol, medication, genetic conditions. But the one that we are interested in today is trying to emphasize the metabolic aspect of it. It's called metabolic dysfunction-associated steatotic liver disease. It's a mouthful. Sometimes I tell my patient you have all of that, and they die right there out of the impact of this, how many weeks of life I have. But the key thing is that it tries to emphasize the metabolic aspects. Again, it has some shortcomings, but the key thing, it's not exactly the same because you also have to have not only steatosis, but one of the cardiometabolic risk factors that you have in the metabolic syndrome with those typical cutoffs, okay? So you already know that. So again, MASLD is not exactly interchangeable, but since 85% of the American adult population already has a cardiometabolic risk factor, even without fatty liver, the overlap between both is pretty high. There's a 5% discordance that happens more in younger adults or people who are non-obese with MASLD or lean, but overall it's working okay. There's also this overlap of alcohol with MASLD called MetLD. So these are people who are not drinking enough to meet the definition of alcohol abuse, but are drinking some alcohol. And these are particularly affected by disease progression. Okay. With that said, we kind of know what we're talking about. And some of the slides still have NAFLD. But NAFLD and type 2 diabetes is like a couple who gets the worst out of each other. Because if you have diabetes, this liver disease progresses more rapidly. And also, the liver disease makes your diabetes more difficult to control. You're more insulin resistant, and likely you're going to have more cardiovascular disease. So again, if you want to look, and I'm going to browse quickly over some slides, and I'm going to send Leandro the PDF. So you can all have it and look at it tonight. Instead of going to a happy hour, you stay and look at some more slides. So, but the key thing here is if you look all over the world, in groups of people with more, in countries with more diabetes, there's also more fatty liver. And as I'm going to show you later, 2 out of 3 people with type 2 diabetes already have steatosis. So that's why we don't do ultrasounds to identify steatosis, but we're going to do a simple test called FIB4 to identify those who have this fibrosis going on and who are on a path to cirrhosis. I highlighted this box in the upper right because that's what we're looking for. How many people with diabetes have fibrosis? Depending on the studies, just remember it's about 15%. So 1 out of 6 people with type 2 diabetes. So if you saw 6 people with type 2 diabetes and you didn't diagnose anyone with NASH or MASH, you missed them. Okay, so, but I'm going to tell you how you're going to avoid that moving forward. Okay, so with that, we're going to move on. This is for you. Now, I'm going to briefly explain why cardiologists should be particularly concerned. And again, there are 5 papers and reviews every day, but I decided to just show you a few. And if you do a search of cardiovascular disease and fatty liver, you pop up 5,000 papers, but they all say about the same. First, that there is an association But as this title says very clearly, we don't know. It's a tangled web of risk factors that cardiologists know better than anyone. The question is the risk beyond the traditional risk factors or not? And again, that's a difficult question to answer. I wrote again. I had to write also a review on this with a young faculty, but don't believe that. This is kind of a very nice review now, 2 years old, from the American Heart Association. And again, the real problem is that typically the population that has fatty liver also has more traditional risk factors. And although you can correct statistically, I don't know if that really is strictly biologically true. But it is important that in the setting of insulin resistance, with all the problems that you're very familiar with, typically you have more increased visceral fat, more muscle insulin resistance, even sarcopenia. I'm going to show you a couple of slides about that steatosis in the liver promotes diastolic dysfunction. Again, many studies. You heard from pericardial fat, again, another controversial issue, and endothelial dysfunction. So this is one slide. And again, I told myself I wouldn't torture you with a lot of these. But if you adjust for traditional risk factors, now, instead of all being yes, increased cardiovascular disease, there's kind of a mixed bag. And again, it depends on your endpoint. For example, ultrasound is a very bad endpoint for fatty liver because for a number of reasons. Liver biopsy is better, but then you have small numbers. And again, you can look at, of course, and angiography is better than CIMT or arterial stiffness. So again, it's a mixed bag of studies of different quality. Now, the other thing that's important is to remember that, again, longitudinal studies have also been mixed and cross-sectional studies. And so I think the issue is not settled, but there's a very good rationale for it increasing risk. We did some little studies. I'm just going to give you a couple of examples. If you look at LDL particle size, again, if you divide in people without obesity or people with obesity and people with steatosis or not, you see that even in non-obese, having a fatty liver is associated with more smaller particle size and more dense LDL particles. One of the many pieces in the puzzle. The other is old studies from Dallas. Dan Stein and his group, we were talking about with Leandro about this, that people with increasing degrees of metabolic dysfunction tend to have more myocardial steatosis. And again, if you look at myocardial steatosis, an independent predictor of diastolic dysfunction, again, this meta-analysis has about 280,000 patients, 12 studies, and find that like a twofold increase in diastolic dysfunction if you have steatosis in the liver. And not surprisingly, because steatosis in the liver is typically associated with myocardial steatosis and other problems. Just as steatosis, an independent predictor of diastolic dysfunction, just one example, and I tried to show you the original studies here that showed that if you measure myocardial triglyceride content, it's as it goes up, it's associated with a lower the ratio of maximal left ventricular early peak filling and maximal left ventricular atrial peak filling rate. And the same happens with E-peak deceleration. So an inverse relationship. Also, it associated with decreased myocardial metabolism. So if you take this study took about 30 individuals with low liver and heart fat or high liver and heart fat, and this is muscle glucose uptake during a clamp, and you see that if you don't have hepatic steatosis, the heart has a healthier glucose metabolism and insulin sensitivity, and it goes down as you increase your liver fat content. And the same is for myocardial energy metabolism as is phosphocreatine over ATP ratio. So there seemed, and then I've just showed you the initial studies. There are 20 studies, okay? So I don't want to torture you with this. So take-home message is to summarize a lot of data. Compared to people without fatty liver, having just steatosis increases more than anything your cardiovascular risk. Now, when you develop this steatohepatitis, then your liver risk goes up, and of course, if you have cirrhosis, you're going to probably die from liver disease. But up to cirrhosis, let's say when you have moderate to advanced fibrosis but not cirrhosis, your number one cause of death is cardiovascular disease. Okay, so you guys are at the perfect point in the natural history of disease to prevent it. So going back to this, we're going to tell you what is the rationale now to find these individuals and what are your diagnostic tools, okay? So we have a very inexpensive first-line test, okay? It's called FIB-4, okay? FIB-4 stands for Fibrosis Index 4 because it uses 4 parameters: age, AST, ALT, and platelets, okay? Why? Age, because with older age, you're more exposed to these metabolic factors that promote liver disease, liver enzymes for obvious reasons, and platelets, because as you develop cirrhosis, your platelets are going to go down. So just a few little tips. Number one, if you're the AST, ALT of 40 is a high cutoff. That's saying, it's like saying, let's diagnose diabetes with an A1C of 8. Normal ALT, AST is 30 or below. Actually, in women, it's 26. So when you have somebody with an ALT of 35 to 40, guaranteed that they have steatosis, particularly if they're obese or have diabetes. If its AST is elevated, the AST is a bigger marker of fibrosis. So you're on the path to cirrhosis. Platelets of below 200,000, particularly below 150,000, big marker for liver fibrosis and probably cirrhosis. So what you can do, you go either to any website, you type in FIB4 index, and there are like 10 calculators that you can use for doing this. We have it incorporated into our Epic. So if you, in your notes, if you have Epic, you put .fib4, and that buzzword will give out the number if you have a CBC or liver panel within the past year, okay? So for example, we also have a calculator. So what we do, we have tools in Epic. We put a clinical calculator and we choose FIB4 and it cranks out the number. See, these liver enzymes wouldn't cause a lot of alarm in many of you, right? It's liver enzymes, our AST is 38, ALT is 40, but look at that low platelet count. This person has a FIB4 greater than 1.3, that's the red flag. If it's greater than 2.6, probably they have advanced liver disease. And I've identified people, a lot of people with cirrhosis just like that. So what are the tools? A tool your hepatologist already has been using for 2 decades at least is the FibroScan. This comes from the viral hepatitis world. And it's very simple test. It also measures the amount of fat in the liver. I'll show you what it does. All your hepatologists have several of these. It's easy. There's a very large body of data, but the device is expensive. The thing is that most hepatologists have it, and they do it around the clock. There's also shear wave. That's a feature of the ultrasounds, and MR elastography, which I'll show you in a moment, okay? So with this is the FibroScan. This is what an older device looks like we had in the VA. Basically, it's not really an ultrasound. What it does, it's a pulse wave that will come back in proportion to how stiff your liver is. So it really measures stiffness. So if you have cirrhosis, your liver is stiff like a rock, if you want to be graphic, and it will give you a higher number. The machine this transducer will convert it into a number, okay? These are the newer ones that are smaller. There's some portable ones. This is how somebody puts it in between the two lower rib spaces. And these are the numbers you need to look at. Number one, the blue is CAP. So fat is CAP, if you want to remember it easily. And again, and the right one is the liver fibrosis. Again, what numbers do you need to remember? 274. There are different cutoffs. Some take 274, probably mild steatosis. And again, 300 or greater is definitely severe steatosis. And for fibrosis, remember 8, okay? If the number is 8 or greater, most likely you already have moderate fibrosis. It's just like having proteinuria, okay? You're going to head towards cirrhosis. So this is where you probably would do good in sending the person to see the hepatologist, okay? So we are not trying to define fat, but we should know for you as cardiologists, if they have fat and a normal fibrosis, that fat is still an indicator of increased risk of cardiovascular disease. The question you can do, how do you integrate it into Framingham and all these other calculators? We don't know. It's not been done yet, but maybe one of you will be inspired to do it. But again, for liver protection and prevention of cirrhosis, remember number 8, okay? And if we do this, this is a paper we published in Diabetes Care now a couple of years ago. In 561 patients, now we have about 1,000 patients with similar results. We did a FibroScan to any person with type 2 diabetes walking into the clinic if they didn't know that they had fatty liver. Again, 70% of people had steatosis, 21% fibrosis. And again, liver enzymes above 40 would have not been very helpful. And if you break it down, look, we had about almost 1 in 10, 9% had pre-cirrhosis or cirrhosis. Again, liver enzymes not always elevated. So liver enzymes if they're elevated, has relatively good specificity, but 2/3 of the people with fibrosis have liver enzymes below 40 or more. So keep that in mind. Another thing, just for your general education, but you're not going to be ordering this, is magnetic resonance elastography. This is the gold standard to identify fibrosis. Again, divides it in these 4 stages. F1 is mild, F2 is moderate, advanced, this is cirrhosis. Again, just for your general information, this is a tool your hepatologist will be using. We also have the liver multiscan that identifies inflammation. Again, this was a female in one of our studies. Again, FIB4 platelets were normal, but this person had FIB4 that was elevated. So we did a FibroScan showing fat and fibrosis supposedly above F2. And again, this shows a lot of inflammation. This should be below 800, say. So again, a tool you don't need to know, but just for your general background information. Finally, a liver biopsy, okay? So I'm putting up here from your medical school years, what's a normal liver. And this is the liver of 1 in 6 of your people with type 2. That actually 1 in 3 of your patients with diabetes have this degree of NASH. And you have this infiltration by white blood cells, neutrophils. This is a liver cell that's swollen. This is a lipid droplet. Again, this is inside the liver cell. The liver nucleus is pushed to the edge. So clearly not a very healthy liver. And when you do this trichrome stain, all this blue is fibrosis. Okay, this person has, depending on the reader, F2 or F3. So this is what you're trying to prevent. And there are 5 million people with type 2 diabetes that have a liver that looks like this. So it's our mission to try to find them. Okay, so how are we going to do that? What does the ADA and other societies want us to do? So number 1 is calculate the FIB4, as we mentioned. And the reason is to try to identify when they have moderate to advanced, if not cirrhosis, okay? And the reason is because we can do something. We can halt cirrhosis where it is and prevent it from progressing with the drugs that we have. And we can probably reverse even advanced stage 3 or stage 2. And we also will be preventing cardiovascular disease and hepatocellular carcinoma with that. Okay. So we made the guidelines for us, endocrinologists, primary care, and cardiologists, with the American Association for Clinical Endocrinologists, with the Liver Society. Scott Isaacs was the co-chair with me, and we tried to make it very simple. This is all you need to remember, and you'll become pros in this. Okay. A, which are the people at the greatest risk? Highest risk, type 2 diabetes with obesity, followed by people with pre-diabetes, or people with, and third will be obesity with cardiometabolic risk factors, okay? Finally, there's this bucket of people who get an ultrasound for gallbladder disease or any reason to have steatosis. You will be surprised that only 1 in 10 of these individuals with incidental imaging get sent to the liver doctor or something's done. And the other bucket is people with elevated liver enzyme. That's the number one cause for hepatologists to see somebody, but not if they're above 30, but typically if they're above 40 or greater. Now, we don't want you to send every person with steatosis to the liver doctor, okay? Only if they have an elevated FIB4. So the two things that we have to do are, number one, prevent cardiovascular disease, that you are the champions. What is new for us as endocrinologists and for probably you is to how prevent cirrhosis, okay? And the way you do it is doing the FIB4 and eventually a FibroScan and putting them in one of these three buckets. Low risk stays with the primary care doctor. Intermediate or high risk goes up to the liver doctor. Now, since you're a cardiologist, one thing I will don't want to forget, if you have heart failure, the FibroScan can give you a higher reading, okay? So heart failure, you probably got to be cautious. So if it gives you a low number with a liver stiffness measurement, you're fine. If it gives you a high number, just take it with some caution, okay? So we talked about this, the FIB4, it can give you a low number. Then you go down this path. You just manage in primary care, cardiometabolic risk factor, risk reduction. High number above 2.6 goes to the hepatologist. If it's in between, you do liver stiffness. There's also a blood test called ELF, a commercially available test by Siemens. It's only just rather expensive. It's more than $300. So use it with caution, okay? And again, these are the cutoffs that are everywhere. Okay, now I want to dive into treatment. Let's see how we are going to integrate drugs that you're already pretty familiar with. So again, we said that ideally we would like to prevent fibrosis, but again, we don't have any very good anti-fibrotic drug. I'll talk to you about that later. So now the current stage of the field is like doing a kind of a shotgun approach. Okay, we want to improve adipose tissue biology, and that's what pioglitazone does, or we reduce the mass of fat by weight loss, either lifestyle, which is limited in its success, or with GLP-1s, or metabolic surgery, okay? Because that prevents all the factors that drive the hepatitis and then the fibrosis, okay? So in this slide, I kind of summarized the drugs that we have today to manage obesity or diabetes. Again, none has been approved by the FDA. No obesity or diabetes management medication has been approved by the FDA. The FDA has recently approved resmetirom. I'll tell you more about that later. But again, I have one slide about bariatric surgery later. GLP-1 receptor agonist, the two drugs that have been best tested are liraglutide and semaglutide. I should say that there is a trial with tirzepatide. We'll talk about it later also, that has shown to help in NASH. And pioglitazone, which is dirt cheap, $5 a month, and has shown in several studies to work. Now, we have to prevent cirrhosis because the drugs that we have are not very effective in cirrhosis. So let's get down to the last 10 minutes of our talk. multidisciplinary team. So diabetes care and other specialists, and hopefully after this talk, and will be seen by all these people on YouTube. Leandro has done a lot of advertisement here for this series. The truth is that I hope that cardiologists get increasingly involved, and also in the cardiovascular risk reduction, because what we see many times in primary care is statins are stopped, and that shouldn't be the case. So any individual with NASH, even if the liver enzymes are elevated, can use statins. You should use them starting at lower doses, but they're fairly safe all the way up to compensated cirrhosis, but you shouldn't use them probably in decompensated cirrhosis. So I want you to become a little bit obesity management and diabetologist in the management of these patients, which also have a lot of benefits for your cardiovascular risk reduction, right? All of you are so familiar with the SELECT study and so many other ones. This is the pharmacological management of diabetes. I'm sure you're familiar with it. I only show you this because we want to add NASH or MASH as the other box that's missing. So I'm working hopefully with ADA for that to happen soon, but we need to consider that we do have options to treat our patients with liver disease. And diving a little bit deeper into this, the three classes of drugs that work, which is pioglitazone, GLP-1s, or SGLT2 inhibitors, the three reduce steatosis. We don't have liver biopsy studies yet with SGLT2 inhibitors, but pio and GLP-1 do work on NASH and may halt progression at least of fibrosis. And they have a lot of metabolic effects on lipids, and improving many aspects of mitochondrial function and so forth. So very important metabolic effects. And then they have all the other stuff that you know so well about. So we're not going to dwell on that. Three things to remember from the ADA guidelines that next year are going to come out basically the same. We are updating them now as we speak this month. Lifestyle changes that promote weight loss, no brainer there. If you have type 2 diabetes, particularly if you're overweight or obese, and you're going to treat that, use a GLP-1 to promote weight loss. And number 3, we talked lifestyle, GLP-1 for weight management, and pioglitazone or GLP-1 or their combination to treat hyperglycemia. So with that, let's dive a little bit more. I'm not going to talk much about weight loss. It's really important, no matter how you lose weight with exercise, hypocaloric diets, orlistat, whatever you use, the amount of weight loss is proportional to how much liver you melt and how much inflammation you reverse, okay? Diving into GLP-1s, you're very familiar with its effects on MACE. We don't have lixisenatide or albiglutide. Down specific to the effects on the liver, you should know, and I gave an updated couple of PDFs to your administrator, Glennie, right? And she should be sending them out. We just published a month ago an updated version of this. But basically, in all studies with a GLP-1, you reduce weight and liver fat goes down. This study by Newsom et al. Is particularly important because biopsies were done before and after 320 patients, okay? So I was also a co-author in this study. 2/3 of the people had type 2 diabetes. We used a daily formulation. The hope from Novo was that it would have less GI side effects, but it was about the same. So that formulation is not going to be continued. And you should know that they're in the midst of a big phase 3 study with biopsies using a weekly formulation. And the primary outcome is if you could get rid of that inflammation with NASH resolution. I'm going to show you 2 slides. This is the key slide. If you use the higher dose, that's equivalent to the 2.4 weekly for weight loss. Almost 6 out of 10 patients had a resolution, no more inflammation compared to 17% of placebo. All the doses were significant. Fibrosis was not significant, unclear why. The placebo effect was like 30%. It could be reader biopsy, noise, or not enough time of treatment. But this is an important slide that divides it in improvement in dark blue, no change in lighter blue. In red, it's progression. So if you go from the lower to the higher dose, you see that the higher dose had very few people progressed after 72 weeks compared to 3 or 4-fold more placebo. So you can slow down disease progression. And this is a very important concept because if you have even compensated cirrhosis that doesn't get worse, you're going to probably not die of liver disease. Now, the drawback of, in general, GLP-1s is that you regain most of the weight. So that's why it's important to be associated with lifestyle changes. And it happens at every dose, okay? So this is the people discontinued the drug at the end of the trial, and then were just followed. And again, unless they're really lifestyle changes, this is a lifelong therapy. And as you see, this is also associated with a bouncing back of these metabolic risk factors. Blood pressure, again, goes back up. A1C goes back up. So you need to explain this to the patients. We're going to shift gears in the last 8 minutes to pioglitazone and SGLT2 inhibitors. As Leandro mentioned, we published the first study in about 6 months, simple study with biopsies before and after showing a benefit. And this was confirmed in other 2 studies in people without diabetes. In our study, half of the people had diabetes, the other half pre-diabetes. Then we published a 3-year study with similar benefits. We combined it with vitamin E, and basically vitamin E didn't do that much, but there was some benefit of the combination. And then there's been another study with the same results. Basically, all studies have shown that pioglitazone, at least half, depending on how you define the endpoint, but at least half will have cure the inflammation in the liver, okay? And the typical finding in green is a run-in period. If you just stop eating poorly, liver enzymes get better. But with pioglitazone, most people get to the ALT below 40. And 2/3 in this study had improvement histologically, about a 50% placebo-subtracted benefit. Now, for this audience, it's very important. Nobody is promoting pioglitazone because it's a generic drug. So maybe the younger doctors don't remember that it has a lot of properties that reverse the factors that drive cardiovascular disease. So in addition to improving the liver, it reduces hyperinsulinemia that can be an atherogenic factor and insulin resistance. You lower glucose, you remove the systemic inflammation. It increases HDL about 20%, lowers triglycerides. And there are several studies that have shown that it reduces fat, heart steatosis, and it improves cardiac output in people without heart failure. It won't do it if you have heart failure, but it does it in people who are healthy. And then there's been, I'll show you one slide about proactive. These were intravascular ultrasound studies showing less progression than with other diabetes make. And then the IRIS study in 3,000 people with insulin resistance that had a stroke or a TIA, and it reduced cardiovascular events. Now, the first thing I have to tell is that there's still people that think that pioglitazone causes heart failure. It enhances and improves left ventricular function if you don't have heart failure. But if you already have heart failure, typically undiagnosed diastolic dysfunction, and you happen to have water retention, that happens in 5% of the patients, that combination will, of course, tip you to heart failure. So after the proactive study, that were 5,000 people with cardiovascular disease, many with heart failure, all the other studies that have been done, and particularly this current study is the largest with 3,000 people followed for 5 years, did not see an increase in heart failure. So this is an important concept that I always get asked, and there's always this concept. So the ADA says don't give pioglitazone to people with heart failure, which is stages 3 or 4, but you can give it to people who don't have heart failure or minimum heart failure. In the proactive study, the primary outcome included people with peripheral vascular disease and or who had interventions to treat it. That was a kind of a soft endpoint. But if you use the typical MACE endpoint, it was positive and it reduced fatal and non-fatal stroke, as well as a fatal and non-fatal MI. This is an important concept. Moreover, I mentioned to you the IRIS study. If you looked at the cardiac outcomes in the, all of you are familiar with the IRIS study, I think, at this point, but some don't know that there have been sub-analysis looking at the effect on cardiac outcomes, and it reduced by 29% this risk. Again, you can look at the curves there, and again, I'll send you all these slides later on. I want to move on to try to understand why, because people, how can it be you get better if you're gaining weight? Typically, the high dose of pioglitazone, 30 to 45 milligrams, you're going to gain 2 or 3% or 4% if you don't modify your diet. The reason is if you have diabetes and you lower your glucose and you're going to be keeping every calorie you eat instead of having glycosuria. That's one mechanism. The other is what happens is there is a shift as your subcutaneous fat becomes more sensitive to insulin, it will store calories more easily. So liver fat goes down, visceral fat goes down, that's highly atherogenic, and you put the fat in the let's say in the back, in the trunk of your car away from your engine, but you're still accumulating fat, but this is less metabolically harmful. And when we published this study recently, what we looked at is which were the 3 factors more closely associated with benefit, and that was an increase in adiponectin, the reduction in visceral fat, and improvement in insulin sensitivity. So basically what happens, you're getting fat outside of the visceral compartment, which is so harmful, to the subcutaneous compartment. Now, I have to say that I don't like any weight gain. So what I recommend doing to prevent that is to use low-dose pioglitazone. So from the IRIS study, there's also a paper by Spence et al. Published in Diabetes, Obesity, and Metabolism that shows that lower doses are less harmful. But I want to share with you studies that have compared 15 to 30 milligrams. There are many, these are the better ones. You see that you still get a reduction in hemoglobin A1C. You will lower triglycerides, increase HDL with very little weight gain. And in these studies, they did not do an active nutritional program, but you can do it and prevent basically all weight gain. The other thing is to combine it with a GLP-1 or an SGLT2, which has already been done. I'm going to show you one of these studies. So if you want to do a low-dose pioglitazone, try 15 milligrams. It's dirt cheap, and it will not be associated with heart failure or really significant weight gain. We're doing a study in NASH, NIH sponsored. But I just want to show in the study where they added to the EMPA-REG, they added pioglitazone. I'm sorry, the other way around. They took people who were on pioglitazone and added empagliflozin. You see that after 76 weeks, you have net weight loss, adding an SGLT2 inhibitor compared to a 1 kilo weight gain after a year and a half with pioglitazone. The other is to add a GLP-1, and this is the SUSTAIN-2 study in which they added semaglutide to pioglitazone or metformin as a background, and you have net weight loss. So use those combinations, start at low doses. I try to avoid if you already are obese or if you already have lower extremity edema. You guys use a lot of amlodipine. Amlodipine causes lower extremity edema. You got to be careful. If you're on massive doses of insulin, insulin also promotes weight gain and edema. And again, if you suspect it, just rule it out, you guys. I don't need to explain you how to do that. And the other thing is maybe some bone loss. So I typically will do a bone density if it's a postmenopausal female. And the history of bladder cancer is kind of dying off because 18 out of 23 studies have been negative, but don't give it to anybody with a history of bladder cancer. So how do you monitor this is start 15 milligrams. If they're doing well, you can increase it to 30. You don't need the 45 milligrams, and check for ankle swelling or any easy fatigability or shortness of breath, and make sure you don't have somebody with heart failure. Okay, SGLT2 inhibitors, many studies, uncontrolled, controlled study. We did one with canagliflozin. Basically, placebo-subtracted weight loss is 2 to 4%. All the studies show reduction in ALT if they're elevated, and reduction in liver fat. So great drugs, but they have not shown yet to have a major impact in NASH. We don't have biopsy studies. To finish, a couple of things. Number one, these individuals with fatty liver have increased cardiovascular risk. Statin therapy is recommended by all guidelines. Don't stop the statins, particularly if they all the way up to compensated cirrhosis. You got to be careful and individualize therapy in people with decompensated cirrhosis. And again, I just want to share with you, this is a nice review that shows statins have a lot of good effects on the hepatocyte at all levels. So you should not discontinue them. And in that 3-year study that I mentioned in ANAS, we had put everybody on statins. And after 3 years, we only discontinued one that actually was on the placebo arm, not the pioglitazone arm, and we found out later that he was drinking. So fairly safe in more than 100 patients. Finally, metabolic surgery. We underutilize it, very useful. You have to use it with caution and avoid it in people with decompensated cirrhosis. I'm going to show you one slide. This is a large study, a database study of follow-up many years, as you see, almost 10. Great benefit on liver outcomes, also great cardiovascular benefits in people with advanced liver disease from NASH, okay? 2 words about future agents. So number one, there are a number of drugs that are trying to do what pioglitazone does with less side effects. And there's also some thyroid hormone receptor agonists, FGF21s and GLP-1s. This is lanifibranor, one of the few drugs that is now in a big phase 3 study. It's a pan-PPAR alpha, gamma, and delta. Great effects on the liver. I'm sorry, on inflammation, effects on inflammation and fibrosis. We have done some insulin clamp studies. Here, I want to highlight some of our wonderful staff, Diana on the left and Andrea on the right. Again, I want to show you that liver fat goes down 50% with lanifibranor, and we improve endogenous glucose production, which is hepatic glucose production, insulin resistance in the liver, and insulin resistance in muscle, and had all the favorable cardiometabolic risk factor improvements of glucose, lipids, adiponectin, etc. So very promising agent. We'll hear from it in a couple of years. I want to highlight here resmetirom. There are other thyroid hormone receptor beta agonists that work specifically on the liver. Again, just a few weeks ago, they published their phase 3 study in 966 patients. Roughly the placebo-subtracted benefit that I show you with GLP-1s, that was about 40%, and with pioglitazone about 30%, was about 20% with this one. Again, however, these are phase 3 studies. The other were phase 2 studies. And again, the editorial that I wrote highlighted first is a big step forward. Second, that the benefit, it was moderate, but it's the first FDA-approved drug, 20% placebo-subtracted benefit compared to placebo. and about 12% at the higher dose on fibrosis. So you have to think what the benefit is, what you're getting, and the cost. The cost is $47,000 a year. So it's not a drug that you as cardiologists or me as endocrinologists are going to be using. We need to leave those in the hand of the hepatologist. And again, in my perspective, after maximizing GLP-1s and pioglitazone, and adding this as an additional drug to those. But again, and also you need to monitor thyroid function test and probably gonadal function and keep an eye on bone health. To finish GLP-1s, we're going to go quickly here. Tirzepatide, about a 50% reduction in fat in this 52-week study. You see the liver is here on red on fire with 27% fat. It goes down to 2.6 fat in some of the patients. You might have seen in the New England this study that shows that the vast majority of people can lose about 10% of their body weight. And this drug has now been approved for obesity in addition to diabetes. And they have announced that it also had positive results in NASH. Retatrutide is a triple agonist, GLP-1, GIP, and glucagon receptor agonist, up to 24% weight loss. This is clearly going to have benefits in NASH and, of course, diabetes and others. So with this, I want to finish. Remember which are the high-risk groups. Remember that, of course, you guys are the champions of cardiovascular risk reduction. Don't stop the statins. Find out if your patient is on a path to cirrhosis and use the FIB-4 and educate your patients. And again, try to incorporate in your management the liver, and prevention is key. And I hope that slowly we're going to be making it into an integrated cardio, renal, and liver-centric approach. So with that, I'm going to just stop. We talked about this. This is my team. And thank you, Leandro, for this kind invitation.
Thank you so much, Kenneth, for this. It was amazing. And I think for myself that I went to University of Buenos Aires as well, it's amazing to see people that came from there and are doing such an amazing job in
such
comprehensive way. You can tell how a good doctor you are in general. So
thank you.
Yeah, of course. So put your questions, please, in the Q&A. I'll start with one about alcohol. You spoke about this kind of gray zone when people may be drinking, but not as much, and they may have also a component in addition to alcohol. What do you tell people? When do you tell people absolutely don't drink, or what's your approach with the interaction with alcohol and muscle?
That's a great question. So number one, a couple of things. So obesity and diabetes promote progression of fibrosis. Alcohol also. So hopefully your patients too, that there's not this healthy glass of alcohol as you thought in the past. But where you should completely stop alcohol is if you have this moderate to advanced fibrosis, so F2 or greater, which would be any of your patients with a FIB-4 above 1.3, confirmed by the FibroScan. So no alcohol because it just causes disease progression. It's definitely. There's a question by Robert Osfeld about the elasticity measurement. No, 24 hours are not going to change that, the measurement. So liver fat can go down with exercise, even without weight loss. But the studies have been a minimum of 2 weeks. But again, liver fat is the easiest one to turn around. Once you have fibrosis, you really need to work hard. 5% weight loss can reduce steatosis, but to reduce the inflammation in the majority of your patients, you're going to need to achieve a 7 to 10% weight loss. That's why, while achievable by a minority of patients, most would benefit from using a GLP-1. And the concept should be that this is likely a long-term therapy because if not, as I showed you, there's a lot of weight regain. It's not the fault of GLP-1, but if you're dying for a hamburger, and that's the core of your diet, or all the junk food, what GLP-1s do, they reduce that drive to eat. They're not hungry. Actually, I had patients saying, I don't want to take it anymore because I enjoy eating and I don't enjoy eating anymore. It also appears to reduce alcohol intake. So there's studies ongoing with that. So the key thing is to promote we don't do diets anymore. We promote healthy lifestyles where you replace junk food for a Mediterranean diet.
Thank you.
So
Thank you.
no easy answers, but clearly exercise is important. But the measurement of CAP and liver stiffness measurement is pretty well standardized. And in the hands of the technicians that are going to do it from liver practices and liver technicians, it's pretty reliable.
Thank you very much. If you want to exit your presentation so we can put the CME code
Oh,
as
sorry,
well for
yes.
people. No, of course. And so we'll put now the CME code that people are asking. And so from Mike Patu, one of our fellows, he's asking more about the GLP-1 receptor agonist. He's asking in particular about the mechanism of action. And I'll tag that into how do you get them approved for people without diabetes? Are we going that way or?
Well, to be honest, that's been also big question. Now, what we do know for sure, we don't know the right answer, but what we do know, there are no GLP-1 receptors in hepatocytes. They might be affecting, from some acute studies, vasovagal factors. But we think, and we have a little abstract looking at extra weight loss effects and genes that change with GLP-1s that are independent of weight loss, but the vast majority of the effect is weight loss. So if you don't lose weight, the effects are blunted. So, and the reason is you are decreasing the mass of adipose tissue. Your adipose tissue is a sick fat that is releasing fatty acids, just like a drip of alcohol in your blood, to your hepatocyte. Your hepatocyte don't have any way to keep those fatty acids outside of the liver cell. So it's like a fat attack. And it can happen also, you ask, how can lean people have NASH? And the reason is that when they look at them, they have sick fat, which is genetically determined. And it's worsened is if you gain weight. So there's lean people who develop type 2 diabetes. There's genes involved, and lean people who develop NASH just because probably their fat and their liver have a genetic predispositions. There's a question by Anna. Is there utility in reading out the liver spleen ratio on CT scans? Yes, I mean, that is a rough measure of liver fat. And if that can be absolutely a starting point for getting a better and greater in-depth evaluation, that's clearly valuable. So I would rather do it. And I would encourage all of you guys who get so many imaging for so many good reasons, that if you identify somebody with fat in the liver or for any reason, that you at least touch base with the primary care or look at a FIB-4. It will take you a minute. And I have identified people with cirrhosis just starting with a FIB-4. So it will be a great service to your patients.
And there's so much value, I think, in even calcium scores that we use a lot, or CT scans now, with contrast and looking a little bit more outside the heart and the different things that we can find there. So.
Yeah, it's really a fascinating field. We're really in the infancy. And again, the FIB-4 will miss some people with moderate fibrosis, but it will catch most of those with the pre-cirrhosis stage. We know FIB-4 is going to be replaced in the future with a better thing. This is like a Windows 1.0. In 10, 20 years, they're going to laugh at us. But well, what we have to develop is this muscle for thinking about it, for keeping them on statins, for following them over time. And I'm sure one of you who have heard this talk, we'll identify somebody with cirrhosis the next week or the following. So if that happens, you've made me the hour together very well utilized.
Okay, well, thank you so much for a wonderful lecture, and I hope you have a great Friday afternoon and weekend.
Take care. Thank you, Leandro. Thank you so
Bye-bye.
much. Thank you all. Bye-bye.